Dr. Jacobe. She is a professor in the Department of Dermatology at UT Southwestern Medical Center. Dr. Jacobe is also on our medical advisory board. So Dr. Jacobe holds the James N. Gillum Chair in Dermatology, and her main clinical and research interest is in morphea and localized scleroderma. But today she's talking more about diffuse and systemic scleroderma. She's a member of the Pediatric Dermatology Research Alliance, and she is also a part of the Childhood Arthritis and Rheumatology Research Alliance. She's one of D Magazine's Best Doctors for 2018 and 2020. So we're very happy to have Dr. Jacobe's talk with us today.
Well, hello, everyone, and thank you so much for coming virtually to my talk here. And what I'm going to be discussing today is what is actually happening in your skin when you have scleroderma. And my goal here is really for everyone who's attending this to really be able to understand what types of changes happen in the skin with scleroderma, why they're happening, and also kind of at least some of the things that you can expect from those skin changes as you go forward in time after your diagnosis. So the bottom line is that skin changes in scleroderma are really a key part of making the diagnosis. And you can see that even in the name, sclero and derma basically mean thickening of the skin, with derma being skin. And so the skin is not only one of the biggest organs that is affected in patients with scleroderma. We'll also go over and how skin changes really are key to making a diagnosis of scleroderma. Also, the changes in the skin are really what define different types of scleroderma, including even what types of internal organ involvement patients might experience. And also, as a dermatologist, I can attest to the fact, and I'm sure many of you can as well, that the skin changes of scleroderma can produce a large amount of discomfort, and they really do necessitate aggressive treatment to help patients feel better. So let's start with what I mean when I say skin changes in scleroderma. And you can see on this slide, this panel is normal skin, and this is scleroderma skin. So you would see this if you took a small piece of skin, maybe about the size of a pencil eraser, and looked at it under the microscope. So for those of you that have had a skin biopsy, this image is probably similar to what was seen in the biopsy from your skin. And what I'd like to point out to you is the differences between normal skin and skin from someone with scleroderma, because I think seeing this really helps you understand how your skin might be feeling differently and why. So starting from the top, this is the epidermis. And this is going to be the top layer of your skin. And this part right here is the part that actually faces outside, that you can see and feel and touch. Underneath the epidermis, in this segment here, you can see is the dermis. And the dermis is where all the collagen lives in your skin and elastic tissue. And in addition to that, this is also where your hair originates in the dermis, or deeper layers. The muscle that gives you goosebumps by raising up your hair lives here. Sweat glands and oil glands also live in the dermis of your skin. So the dermis is actually very important in terms of growing things like hair, sweat glands, and oil glands. And it also is really the part of the skin that gives your skin its elasticity or mobility. So when you have too little dermis, like we do when we get older, we lose collagen and elastic tissue, and that's why we get wrinkles. In scleroderma, the problem is this space, the dermis, becomes imbalanced, and what you get is too much collagen and no breakdown of collagen, and that starts overgrowing and it starts squeezing out a lot of these other structures. And so if you look at this side, all this bright pink stuff that you see here is collagen, big thickened bundles of collagen. And you can see immediately there's a huge difference, because in normal skin, the collagen has a lot of space between it. You can see white, and you can see that you have your sweat glands and your oil glands and your hair follicles follicles. And you can see here, in this case, you actually see that those have been crowded out by all this overgrowth of collagen. Another thing that's really interesting in scleroderma is that the epidermis, the outer layer of the skin, thins, and we don't know exactly why that is, but you can see here that it's thinned. And so this can have a lot of different effects in terms of your experience of your skin. All this collagen makes the skin thickened and hardened and less pliable. And then also the loss of the sweat and oil glands will cause you to sweat less in the areas that are affected. Also, the skin becomes much drier because of the loss of the oil glands. And some people also experience loss of hair. Most commonly, I see it on the forearms in patients with scleroderma. And so this is really what's going on underneath your skin, but it really is also going to be a lot of the problems that you experience with your skin as you have developed the scleroderma skin lesions. So the other thing to know is that what I showed you is really the early stage of scleroderma skin changes, and it actually changes over time. So scleroderma skin disease is not a static problem, it actually evolves. And so the first thing that patients often experience is edema, which means swelling. And this is inflammation, and all the inflammation brings in fluid into the skin and swelling. And this is oftentimes when people have very puffy fingers. They actually can go up and down and be less swollen and more swollen. Rings don't fit. Sometimes if the legs and feet are affected, shoes are tight. This is followed by a sclerotic phase, and really the photo I showed you before from the skin biopsy reflects the sclerotic phase. And this is where rather than kind of the skin becoming more or less swollen over time, it transitions to being thickened and hardened with a lot of collagen deposition in the skin. And this is when the fingers sometimes even become less swollen, but this is when it really becomes much more fixed, and you start getting a lot more problems with mobility. Potentially. Ultimately, what happens is that for reasons we don't quite understand, this process shuts down and you actually start reabsorbing collagen. But what's a mystery is why you don't just kind of go back to normal. And this is something that's being really investigated by John Varga and others, is why do you then go to an atrophic phase, which means you actually have too little collagen and you actually have too little fat under the skin. And so important to remember that everyone can be in a different stage, and each of these stages lasts a different amount of time for different people. So it can be very varied. And some people never get as much of the atrophic phase as others. So there can be a lot of differences between people in how they go through these phases, both in terms of the severity as well as how long the different phases last. So here's just an example of someone, and ideally we really want to have people diagnosed in this phase, because this is the phase, the early phase, where you have sclerosis and edema and inflammation, where treating the skin disease can be most helpful in terms of returning the skin to be much more pliable and returning things like hair and sweat glands and oil glands. And so what you can see here with this particular patient is you can actually appreciate the folds of her fingers are thickened because you have all this extra collagen. Remember all that big, thick pink stuff in the picture under the microscope. And you can see she has some decreased ability to move her fingers. The atrophic phase happens later, and like I said, it happens to varying degrees, so there's a lot of variation. But what you really see here is like what we talked about, is there's really thinning of the skin, and you can see the skin becomes thin, shiny. It's very easy to get sores because the skin is so thin and shiny, and oftentimes here too it feels very tight and bound down. Unfortunately, when you get to this phase of scleroderma skin disease, the treatments that we have, at least now, tend not to work as well. So the window where we really want to intervene is much earlier in the edematous and sclerotic phase. And this is just to show you once again that skin disease in scleroderma is not static. And so you can see here a duration in years, and you can see that between two different types of scleroderma, the diffuse cutaneous and the limited cutaneous, and we'll go over what exactly that means in the next slide, you can see that with the diffuse cutaneous disease, you see a very steep incline of skin thickness that happens really within the first few years after the onset of the disease. So oftentimes in these patients, the skin thickening starts simultaneously with the onset of their Raynaud symptoms and progresses very rapidly to be proximal to the elbows and involve a large area. And then it ultimately peaks as you get closer to 5 years out, and the skin can actually soften on its own without treatment. However, in these cases where we really want to be able to initiate treatment for skin disease is in this window here, particularly early on, because what we hope is by doing that, we can actually prevent people from hitting this peak, and hopefully they'll hit a peak here and have a much faster decline towards more normal skin. People with limited cutaneous disease, which is sometimes called crest, tend to have less severe skin involvement. So you see they don't get quite the same amount of skin thickness. Oops. And it starts to, worsens much more slowly. You can see here it might worsen over about 5 to 10 years, and then it kind of plateaus, and you don't see perhaps as much change in skin thickness. And this really tends to affect the hands predominantly in this group of patients. So this gives you an idea of what to expect. And also, hopefully, you know, if you do think you are in this stage of the evolution of your skin involvement with your scleroderma, it's really important to seek care with a dermatologist or rheumatologist familiar with this condition who can put you on appropriate treatment. So moving on to what another part that's important to know about your skin and scleroderma is the diagnosis of scleroderma really relies on skin changes. And then here you can see this is actually a publication that talks about when to suspect scleroderma in patients. And what they say here are key feature or red flag whose presence should raise suspicion for early scleroderma include Raynaud's phenomenon and puffy or swollen digits and the presence of a positive ANA. So it's really almost impossible to have a diagnosis of scleroderma without the changes, particularly in the fingers. And then you can see here, this is the American College of Rheumatology criteria for the diagnosis of scleroderma. And you can see here, these are all the criteria listed, but the yellow box includes the skin changes. And basically what this shows in a nutshell is that skin thickening of the fingers of both hands extending proximal to the metacarpophalangeal joints, which is right here, it's this joint. So if you have skin thickening that goes beyond here, this basically meets diagnostic criteria to have scleroderma. So I think this underscores really how critical changes in the skin are to the diagnosis of scleroderma as well. And so this is what, when you see someone or when you first had your diagnosis, likely people were looking for these changes in the fingers, and particularly if they were going over the hand as well. And you can see here, you can also have a diagnosis of scleroderma if just the fingers are affected, but you also need to have some of these other features as well to meet the threshold. Also, skin changes not are only helpful for diagnosing scleroderma, they also identify different types of scleroderma. So you probably are aware that scleroderma can be divided into limited cutaneous involvement and diffuse cutaneous involvement. And the important point here is you might have heard the term limited scleroderma or diffuse scleroderma or systemic sclerosis. And that's really misleading because people frequently think that that means, oh, it's limited internal organ involvement or it's diffuse internal organ involvement. And that's because people frequently forget to put in the word cutaneous, which means skin. So when you say limited, what you're really saying is limited skin involvement and diffuse skin involvement in scleroderma. And that has actually a accepted definition, and that's illustrated here. So limited skin involvement is defined essentially by having skin involvement that's only goes out from your elbows or out from your knees. And you can also have facial changes with limited cutaneous scleroderma. Some patients might only have involvement even of the fingers and toes and the face. But the key here, what we really think of the cutoff point is this, it really stays past the elbows. In contrast, diffuse cutaneous scleroderma, it has involvement that goes up the body past the elbows of the skin thickening and hardening. It can involve the trunk and the thighs, and then of course the face is involved as well. But you can see across all of these, the hands, thickening of the skin on the hands is integral to all of these, and that's reflected in why it's part of the diagnostic criteria for the disease. So why is it important to know what type of scleroderma you might have? Well, one thing is that it actually can tell you a lot about the course of scleroderma. Now, these are generalizations, so it's really important to remember that when you talk about something with a large group of patients, it doesn't necessarily predict you specifically. But what we know is that patients with limited skin involvement, that is, again, all past the elbows and maybe the face. And they tend to have more of Raynaud's phenomenon, which is the cold-induced changes in pain in the hands. And then they oftentimes have GI tract involvement, but they have less risk of kidney disease. And sometimes these patients fall into this category known as crest, where you can see calcium in the skin along with the Raynaud's, the GI, the reflux, from the esophagus, and also the broken blood vessels or telangiectasias. These patients have, if you get a blood test, oftentimes have centromere antibodies as part of this. Diffuse cutaneous disease is, like we talked about, it really includes thickening of the skin on the trunk. And so it actually tends to have an onset where you have Raynaud's and skin thickening almost at the same time. Oftentimes these patients, because they have such severe skin involvement, also have inflammation of muscles and joints. And these patients, you really need to watch out and be very, very careful with your lungs and monitor your blood pressure closely due to the potential for kidney involvement. And so the thing is here is when you know this, you can actually be much more proactive in making sure you're monitoring your blood pressure and getting your CT scans and your pulmonary function tests. Now, this should happen irregardless of which type of scleroderma you have, but in those with the diffuse cutaneous disease, it's especially important. So you really want to be sure that you and your team of providers are really on top of that. And if you get a blood test, what you'll find is there are certain results of that blood test that go along with this. So you'll oftentimes find that patients with this type of diffuse skin involvement have anti-topoisomerase and RNA polymerase antibodies. So one of the things is, I'm old enough now that when I first started seeing patients with scleroderma, the general wisdom was that, oh, you can't really treat it. There's nothing really that helps it. And a lot of the patients I saw had never received any treatment for the skin manifestations of their scleroderma. If there's one thing I can leave you guys with today is that really is no longer the case. There's a lot of evidence now that treating scleroderma skin disease can be helpful in terms of making sure people don't get to the degree, hopefully, of severity of skin disease where they get so much thickening and hardening. It can also make the decline in the thickening and hardening faster, so you get your skin starts feeling better and you start getting more mobility sooner. And the other thing I'd like to leave you with is there's a window of opportunity for this. And remember that curve I showed of the skin changes? The window of opportunity is when the skin is still thickening and hardening or at its peak. But once you get into the atrophic phase, or where it's really softening on its own, the treatments don't tend to have as much impact. So you really want to be able to identify these changes and then get to a provider who can treat your skin kind of with what we know now as the standard of care. So when I see a patient with scleroderma, I'm thinking about how can I treat their skin? And I make that decision based on the factors that are listed here. The first is, what does their skin actually look like and where are they in the progression of their scleroderma skin disease? So the first thing I'm looking for is, do they have that diffuse, kind of more all over skin involvement, or do they have that limited where it's really mostly involving their hands type skin involvement? And then do they have an overlap with other conditions? Sometimes I see patients who have other autoimmune conditions like scleroderma plus something called dermatomyositis, or scleroderma and lupus. And of course, that makes a difference in what we're thinking as well. I also think about, where are they? Remember those curves? I'm trying to ascertain, where are they on the curve of how their skin disease is evolving. The other thing that's really important to think about is, what organs are we dealing with that are currently involved with their scleroderma? Because, you know, there are going to be different treatments that are aimed at different organs, and I don't want to give someone a medicine just for their skin if they also need treatment for their lungs. So I would want to give them a treatment that works for the skin and lungs if that were the case. So oftentimes, if I meet someone with a new diagnosis, I have them get testing for their lungs and look at all these other things, so we have a good picture of the overall status of their scleroderma, and we can make a decision in terms of which treatment is going to hit all of these the most effectively. The other thing to remember is that scleroderma has multiple phases as a disease. So a lot of what I've been talking to you about so far is really the result of inflammation in the skin. But there's another component to scleroderma that is the vascular component. Those are the blood vessels. And the blood vessels can clamp down and cause problems like Raynaud's phenomenon, that also can be part of the problems with the GI system and the reflux and those issues. And it can also be a part of some of the pulmonary artery hypertension or the heart-lung issues that we see. And that's going to be very different, because the treatment for inflammation versus the vascular are two totally different things, and they don't have any overlap. The other thing I'm thinking about is, are any of these, if they are the result of inflammation, are they at this point reversible or treatable, or have you reached a point where you have, remember that atrophic phase, where it's very hard to reverse those changes, unfortunately, with the treatments we have currently. So that's all the things that are going on, hopefully, in your provider's mind as they assess and think about different treatments for patients. And so, as I said, one of the first things I do when I meet a patient who's newly diagnosed is I oftentimes work with their rheumatologist to make sure that they have had workup for internal organ disease, because again, what we'd want to do is select a treatment that treats both the skin as well as these internal organ involvements, so we can treat the whole individual and all the different manifestations of their scleroderma. So treatment of scleroderma skin disease base is, like I talked about, based on the subset, the stage, and the internal organ involvement. And one of the things that has really changed in my time in practice is the aggressive treatment of severe skin disease in scleroderma. And so there are a group of patients who have very severe early onset skin disease with their scleroderma. They have that diffuse skin involvement where they've evolved very rapidly to have a large amount of their skin involved with thickening and hardening of the skin. They oftentimes also have changes in their lungs that have evolved simultaneously with the skin. And like I said, they can also have inflammation of the joints and muscle underneath. And those patients are the people you really want to catch early. And the big change has been that those patients are now individuals who are treated aggressively and early. And so the options here really are to refer those patients to a center that is familiar with scleroderma. And the Scleroderma Foundation is wonderful in that they have a good listing of those. And there are some centers now, such as here in Texas at MD Anderson, where they do autologous bone marrow transplants. And I think Dr. Mays can speak to that. I know she's speaking today as well, or intensive immunosuppressive therapy. And the goal here is to really shut this down to prevent progression and severity of both the skin and internal organ involvement. So this is really an important group of individuals who do have this. You really do want to get their diagnosis and get them treated as quickly as possible. Now, in patients who don't perhaps have that severity or that rapid onset of their scleroderma skin disease, there are a number of other treatment options. And again, for all of these, they're going to be really the most efficacious in people who have the early onset where it's still worsening diffuse skin involvement. And this is an old drug, but it's still a good drug. It's methotrexate, which has been used for years for rheumatoid arthritis and psoriasis. And this is a really good option for patients who predominantly have skin involvement, but they really don't have any lung disease at all. And the European recommendation is that methotrexate is for first-line treatment for involvement in early, less than 3 years since onset progressive skin disease with diffuse involvement. So this is still used. But the drug that's really replaced methotrexate is this one, which is called Mycophenolate Mofetil, also known as Cellcept, and a related medication called Myfortic. And basically, the reason I think that this has surpassed the use of methotrexate for most patients, at least in our center, is that it has been shown to improve the skin, which is the modified Rodnan skin score. But it also is known to be a first-line treatment for interstitial lung disease and systemic sclerosis. And so, and it has a bit less toxicity and better tolerability than the methotrexate. And so I think that this has really become a first-line treatment for most of the patients that I'm seeing now for treatment of both scleroderma skin disease as well as the lung disease. And again, as with all of these, early progressive diffuse skin disease are going to be the patients that respond best. So really, methotrexate and Cellcept are the main two drugs that I see my patients on and that I prescribe. Now, if patients do not tolerate these medicines or are unable to take them, or if they don't work very well, which, by the way, it takes about 3 to 4 months for these to start working, so they are not fast, there are some other medications that are being used now. And these include intravenous immunoglobulin, also known as IVIG. This is infused through a vein. There are some smaller studies that seem to show that this does have benefit in scleroderma skin disease, similar to Cellcept. And so this is definitely an option. Most insurance will not cover this unless you have tried or failed or are unable to take the other medications because it is exceedingly expensive. Similarly, rituximab or Rituxan is another treatment that we use for patients after methotrexate or Cellcept. And this has also been studied in scleroderma lung disease as well. And you can see that here. And so this is an option for patients and also has potential to treat the lung disease as well. The IVIG, on the other hand, has less benefit in lung disease, but it can be very helpful for muscle involvement. Another option that is under consideration is tocilizumab. The study of this actually, it failed its primary endpoint for skin disease, but it did have some promising secondary endpoints. And so this is still under study as a potential treatment for scleroderma skin disease. Another one that is up and coming is Edematous, which is currently under study as well. And at the ACR in 2019, there was some promising data presented with that. One thing that dermatologists offer at limited centers, not all across the country, but it is available here at UT Southwestern and MD Anderson in Texas and some other sites across the country, is UVA1 phototherapy. And you can see here, this is the spectrum of UVA1 phototherapy. And there are some studies that looked at changes in the hands in patients with scleroderma with UVA1 phototherapy, as you can see listed here. And what you can see that this photo shows is that after treatment, the patient had increased ability to pinch or move the skin, so the skin thickening was improved. And you can see also here the finger improved as well. So there is some efficacy for UVA1 phototherapy in scleroderma skin disease. However, subsequent studies have shown that it might not have worked as well as we thought. But the problem is that these studies are limited in that they only looked at hands, as you saw with the photo. And I will tell you, irregardless of what you treat with, whether it be an oral medication, an IV medication, or phototherapy, unfortunately, the hand changes, the thickening of the skin in the hands tends to respond the least and the most slowly. So if you do a study like they did with UVA1 where you just looked at the hands, it would be very difficult to know how efficacious it really is. But what we really need are studies of UVA1 that look at the whole body, like the ones that have been done for things like methotrexate and CellCept. And that's something I would really like to do moving on towards the future. But I'll just show you some photos from my own patients that I've treated with UVA1 therapy. I will tell you some of these patients simultaneously did receive oral immunosuppressive medications as well. So this patient I saw, and she was also received CellCept, but she came in with very, very thickened and hardened skin. You can see here she can't complete a fist. She has a lot of swelling still in her digits, and you can see actually here her arms are very swollen and red. So this is really the opportunity we have to intervene with the most benefit. And she had diffuse cutaneous involvement where she really was having a hard time even getting dressed and undressed because her skin was so tight. And we treated her very aggressively with UVA1 phototherapy and CellCept, and we actually got her skin disease in remission. And I've been seeing her probably now for more than 10 years. And she has maintained that improvement in her skin and has continued to have softening of her skin, unfortunately with the exception of her hands, which have, like I said, improved the least and maintained with the most thickened skin. Another skin manifestation of scleroderma that we see that can be is not dangerous and generally doesn't cause symptoms, but patients find very distressing is what we call salt and pepper pigmentary change. And you can see this picture here of this young woman, and you can see why you call it salt and pepper, because you have these areas of lightened skin with the dark dots that are actually around hair follicles. And the UVA1 phototherapy can be quite helpful for this. You can see here she is after receiving some UVA1 phototherapy. So you can really sometimes repigment the salt and pepper pigmentary change with UVA1 phototherapy. This has not been really studied for the oral medications, so we don't really know if oral medications help for salt and pepper pigmentary change, but it appears UVA1 is a good option for that, even in patients who the thickening and hardening of their skin has resolved. And you can see here, this is her leg, and you can see here after treatment, she had a lot of return of her normal skin color to these areas. She was very happy also because her chest was repigmented and she was able to wear a shirt, that had a V-neck and such after treatment. So there are things that can be done for some of the other skin manifestations of scleroderma as well. So when you think about an overview of scleroderma skin treatment, it's always in the context of the subset or type of scleroderma, the overall status of the individual in terms of their other organ involvement and the progress of their disease, where they are in their disease over time. And the big points are that diffuse progressive skin disease, especially when it first starts, is going to be the time to intervene. And in severe cases, you really want to intervene with very aggressive treatment. If patients have arthritis, then the things to consider are methotrexate or rituximab or tocilizumab, because those are going to have a benefit for both the skin as well as the joints. If they have myositis, which is inflammation of the muscles, we like methotrexate or IVIG or rituximab, because again, those work for both. and interstitial lung disease, the CellCept or Mycophenolate Mofetil or Rituximab are going to be medications that are helpful for both of those conditions. If the skin disease is refractory, you can add UVA1 or IVIG or Rituximab. And then if you only have skin involvement without other organ involvement, you can again treat with any number of these, as well as looking at the severity and the phase of their skin disease that they are in. So other skin problems in scleroderma to be aware of include this, and this is something that I find is not frequently discussed among providers of patients taking care of scleroderma patients, and this is itching. Pruritus is itch, and this is from the Canadian Scleroderma Registry. And what you can see here is that almost half of the patients, 45%, reported itch in this group of patients from Canada. And what was really interesting as they analyzed this data is that even when they accounted for things like lung disease and involvement of the gastrointestinal tract, itch in and of itself still had a negative impact on the life quality of these patients, even accounting for the internal organ involvement. So itch, we know, can make people miserable. So it's important, if you are experiencing itching, that you discuss this with your provider, and so they can take actions to help treat you. Why people itch with scleroderma is unknown. There are a lot of different theories as to why it might be happening. One thing to be aware of is patients with scleroderma can have a liver condition called primary biliary cirrhosis. The two can go together, and about 10% of people with scleroderma might have this. And one of the things that it can present with is itching. And so it's important that you make sure, if you are very itchy, that your doctor might want to take a look at some blood tests for your liver status, as well as a blood test called an anti-mitochondrial antibody that, if present, is a strong indicator of primary biliary cirrhosis. Unfortunately, we don't really know why people with scleroderma itch, so we actually don't know the best way to treat them. So oftentimes it's trial and error in trying to address itch. So what should you do if you're itching? One might be that rheumatologists are very well trained, especially at a specialty center, with a lot of the manifestations of scleroderma, but they are less familiar with itch. So you really should see a dermatologist familiar with scleroderma, and the Scleroderma Foundation is a great resource for that. There's also a medical dermatology society and a rheumatology dermatology society that lists providers who really have an interest in complex medical dermatology, and that's the type of person you want to see. So the first thing we would do in that case is we want to make sure there's not another reason why you're itching other than the scleroderma skin disease. And we already talked about checking out your liver. We might look at what types of medications you're taking and any other medical conditions that can cause itching, such as thyroid problems and others. So that would be the first step. We would also, if we don't find anything else and we think that the scleroderma is related to itch, sometimes people with inflammation in the skin, irregardless of cause, including inflammation from scleroderma, can be itchy. So if you were in that inflammatory stage of scleroderma, we generally find that treating the inflammation of the scleroderma with the same treatments we discussed before can also help with the itch. Also, there are general measures that can help decrease itching. So one of the big general measures to think about is moisturizing, because remember that picture of what the skin affected by scleroderma looks like under the microscope. You lose sweat and oil glands, so the skin can become very, very dry, and it also is very easily irritated. So you want to be gentle with your skin, and the most important thing is, you know, really, really moisturizing. And what you want is something that is unscented, thick and greasy. So if you put it on your hand, it just stays there in a blob. It doesn't run anywhere. Patients who really have dry skin, I actually recommend, I should have gotten the jar, but a pound jar per week or every 2 weeks applied after a bath or shower. So you can literally put it in the shower with you so it's nice and warm, pat yourself dry and then coat yourself in the moisturizer. And you might even, if especially during the winter months, need to reapply throughout the day. And this in and of itself can actually improve itch substantially for a number of patients. So another, I guess, you see the changes in the skin, but it's really a problem with the blood vessels that you see in scleroderma as Raynaud's phenomenon. And this Raynaud's phenomenon affects probably 90 to 95% of people with scleroderma. So it's as common as the skin changes. And what Raynaud's phenomenon is, you can see here, this is a cartoon representing the blood vessels of the fingers and hands. Although you can see Raynaud's phenomenon on the feet, I've even seen it on the ears and nose. What's happening in the blood vessels is they are actually constricting, and you can see here they're clamping down. And so what happens is you don't get enough circulation to the fingers, and they turn white due to the lack of blood. If it lasts long enough, what's actually happening is that you start losing oxygen, and it turns blue because you actually don't have enough oxygen to those areas, and they're turning blue. And oftentimes at this point, you start getting pain as well, because what's happening is the cells and the things living in your fingers are crying out for oxygen, so that is manifested as pain. What eventually happens is the episodes break, either due to just unknown factors, warming, or use of medications, and the blood vessel opens up. And so all that blood rushes into the fingers, and they actually turn red thereafter. So Raynaud's phenomenon is, again, something that is common, and for some patients can really cause them a lot of impact in terms of their life quality and the function of their hands. So treating Raynaud's phenomenon is really very important, as important as treating the inflammatory skin problems and thickening of the skin. So non-drug treatments are really important. You want to keep your whole body warm and also manage stress. And smoking is a terrible aggravating factor, so it's important to minimize or stop smoking. Also, take a look at what types of medications you're taking that might be worsening the Raynaud's, and these are listed here. And so if you are on one of these medications, you would want to talk to the doctor that prescribed them about potentially changing them out if you do have severe and uncontrolled Raynaud's. One thing that's really not talked about, I think, is often with Raynaud's is actually movement, and exercise is a great way to break Raynaud's episodes and also prevent them. So anything that kind of gets you up and moving and gets your heart rate up, if you are able to exercise, is really helpful, because what that does is you naturally dilate your blood vessels when you do that. And so that's an important non-drug mechanism to treat Raynaud's. If these measures don't work, then what we do are usually oral medications. And most commonly, most people start with a calcium channel blocker. These are called nifedipine or amlodipine or felodipine. And then you can also change to what is a PDE5 inhibitor, which is things like sildenafil or tadalafil, the topical nitrates or losartan or other medications. And then if that doesn't work, you can try combination treatments and you move on down from here. But again, this is something that can be a real cause of misery for patients with scleroderma. So it's important to discuss these symptoms with someone familiar with the disease who can walk you through going through these different options for treatment. So a couple of questions that I get frequently from my patients that I've seen over the years, and I thought I would address them with you guys here today. So a lot of my patients really are very distressed by the changes that scleroderma produces in the skin of the face. And you can see here this patient manifests almost all of them in that she has the red spots, which are called mat-like telangiectasias, which are blood vessels in the skin, often seen several years after the onset of scleroderma. She has decreased oral aperture, so she can't really open her mouth very far, which makes it difficult for eating, brushing your teeth, going to the dentist, the whole range of things. And then she has, you can't see it because her mouth is open, but she has the wrinkling around the mouth, as well as she also has kind of lost the fullness of her lips. And these, when present, it varies from individual to individual, but for some people certainly is very, very distressing. And so one of the first questions many of my patients ask is, what can I do for all the changes of my face? Because I really don't even feel like I look like myself, and I just like to look more like myself. So we actually have a very active practice where I am. I don't do cosmetic procedures myself, but my colleagues that I collaborate with do. And we have a very active practice of using fillers to increase the volume of the lips and sometimes even the cheeks and other areas. We use Botox or botulinum toxin as well as fillers to address the wrinkling and furrowing around the mouth. And we use hyaluronidase and Botox that sometimes can help increase the mouth opening a little bit. It's not dramatic, but even in these cases, if you increase the oral opening by 0.5 centimeter to 1 centimeter, it still can be really helpful and make it easier to eat and brush teeth and see the dentist. And then we have various lasers that we use for these red spots or mat-like telangiectasias. So yes, it is okay to get cosmetic treatments to address changes from scleroderma. But what I can say is you really want to work with a dermatologist or plastic surgeon that has some familiarity with the condition, because if they don't, they might be hesitant to treat, or they might advise treatments that are less than beneficial. So another question is, which cosmetic treatments should I avoid? Like we talked about, the skin in scleroderma can be very dry and easily irritated. And so you want to be gentle with your skin and avoid anything that is irritating or drying. I generally don't recommend, for those reasons, chemical peels or retinoids like Retin-A and some of the others. Obviously, people with Raynaud's should avoid cold. So cryotherapy, I don't know if where you live, but where I live in Dallas, they have these places where you can go, get sprayed with liquid nitrogen or something like that. Not a good idea if you have Raynaud's. And any procedure that requires extensive wound healing, particularly in an area affected by scleroderma. So some of the more aggressive laser facial resurfacing facelifts, and those with diffuse cutaneous disease who have a lot of trunk involvement, abdominoplasty, tummy tucks, and breast augmentation, or those things, because there is a concern for healing. Now, that being said, I would never advise someone who needs to have surgery because, say, they need to have their gallbladder out or they need to have surgery for breast cancer. In those cases, of course, we would want the life-saving procedure to occur, but cosmetic procedures probably are best avoided just due to risks of wound healing. So another question that I think everyone with scleroderma should know about is that people with Raynaud's can get, not everyone, and this is thankfully a rare event, but you should be aware that you can get what is called critical digital ischemia. And what that essentially is Raynaud's that is not breaking. And so what you can actually see, as you see in this photo here, the fingers can turn white for prolonged periods. And when I really get worried is when the fingers turn dusky or dark like this for prolonged periods. And warming and taking the medicines for your Raynaud's do not break it, and it becomes progressively more painful. And what this means is you've gone from having that reversible clamping down of the artery that opens again to, for some reason, that artery is staying closed and you've actually are losing circulation to a finger or multiple fingers. And this is actually a medical emergency because you need to have an intervention that is aggressive and early to try to prevent permanent damage or loss to that finger. So if you experience this, call your rheumatologist immediately, speak to the person on call if it's after hours or the weekend. And you can be admitted to the hospital actually for IV medications to try to restore blood flow to that finger. And so this is very important to recognize and jump on. And unfortunately, so many patients I see are not well informed about this and don't know what to do. So hopefully now you know what to do. So thank you for your attention. I really enjoy working with the Scleroderma Foundation and the patients in the support groups. So it's been a pleasure to be invited to this. I also thank the Scleroderma Foundation that has supported me in my other research work in terms of grants and funding. It's a wonderful organization and I'm so happy to be here. So thank you.
Thank you, Dr. Jacobe, so much for the presentation and the thoroughness of it, that you covered so many different areas. We have a few questions, if you don't
Sure.
mind taking a couple of questions.
Oh, no.
So I'm glad you addressed some of the therapies that can be done, for the face, and then the ones that we should avoid. So that's really very helpful, because we get a lot of questions on those, especially on some of the online websites. Um, I want to ask you a couple more questions about some therapies that people are using just sort of on their own, trying to treat it, and see what your thoughts are on those. Some scleroderma patients have talked about using the paraffin hot wax
Mhm.
machines, from home, to kind of
Right.
warm their hands up, or to put lotion on and try to get that lotion to absorb into their hands. What do you think about those?
Oh, thank you so much for bringing that up. I actually have patients, some of my patients use those as well. And I think as long as you just want to be careful that it's not too hot where it burns, because obviously burn wounds are to be avoided. And so as long as you're careful that the paraffin is not hot enough to burn, I think it's a wonderful option. I have patients too that do the paraffin and then they have those mitts, like where you can get them
Mhm.
from on Amazon or Nail Supply. They'll do the paraffin, a plastic bag, and stick their hands in those warming mitts. I think that that's a really good option. You can use it on feet as well. The only other thing, aside from being too hot, I'd be careful about is I would try to stay with a not something that doesn't have a lot of fragrance, and I might avoid it if you have any open sores, and hold off until those are healed.
That's very helpful. Thank you so much. I appreciate that. And also, some people talk about using an infrared sauna, whether they use it at their health club or can happen to get one at home. Just thinking that maybe that will help them sweat a little bit. Anyway, just like to hear your thoughts on that.
Yeah, I think that that actually, again, is fine. It does kind of give you that heating. There are some studies that I saw presented several years ago in Europe looking at infrared light for scleroderma skin disease that, very, very preliminary. So I would never say that, oh, this is proven to work, but that maybe had some benefit. So I think, again, it is unlikely to be harmful, obviously, from the obvious of not getting overheated, but I think can be helpful just in terms of warming and treating some of the Raynaud's and things like that.
Thank you. That's useful. It really is, just to hear those, because you kind of are never really sure, because they'll
Mhm.
talk about the benefits of it, but with scleroderma, it seems like our disease is a little bit more unique, that people aren't really going to address on the product side of things. So I appreciate that.
Oh, one other
Um,
thing to add,
mhm.
a lot of my patients have been buying the battery operated vests and jackets that have
Yeah,
heating coils in
yes.
them. I'll just throw that out there. A lot of my patients really love those because they have heating coils in the pockets too, so you can turn it on and stick your hands in the pockets. And now's a good time because they'll probably be on sale for the end of the season. But I've had a lot of I'll throw that out there, patients who really love those.
Oh, that's great to know. I was wondering about that too. So I appreciate it. I carry around my hand warmers all the time, but something like that, where it's like the whole body would be warm, seems like that would be really helpful. Thank you. I did want to ask one other question about, we didn't dive into it a lot today, but there's the Scleroderma Forum, which I have just heard all sorts of recommendations about how you're so excellent at it, amorphia and linear scleroderma.
Oh
And
yeah,
are those
my
different or similar to limited and diffuse scleroderma?
Oh, that's a great question. And morphia is actually where I do my research. So happy to come back another time and talk about that. But
Okay.
in a nutshell, totally different diseases. And unfortunately, the nomenclature is very confusing because you have, the limited cutaneous systemic sclerosis, and then they call morphia localized scleroderma.
Yeah. Right.
Um,
Right. Right.
but so it makes it very confusing because of the way things are named. But what I can say is I have now um, about 900 patients I follow with morphia, including the linear form of it, and they do not go on to develop systemic sclerosis or scleroderma, and vice versa. And so to me, those are two very different diseases. They occur in very different people in terms of that linear scleroderma or linear morphia occurs predominantly in children. They're treated very differently. The linear morphia tends to be very responsive to methotrexate. So in my mind, they're very different conditions. And I think what's important to know is morphia does not have the same internal organ involvement as scleroderma either. So again, very different. And I'm happy to talk more because there's a lot of misinformation about morphia, unfortunately. Um, Scleroderma too, but morphia less so.
And I know when we talked to you, we specifically said, "Hey, this is real common," and so kind of focus on the sort of the diffuse and limited scleroderma. So appreciate you focusing on that today. Then, and we'll get to spend some time on the morphia and linear scleroderma then at some other time. But I think we're running short on time right now. But if people have questions, can we go ahead and sort of maybe follow up with you at another time on some of the questions?
Yeah, happy to.
Okay. Thank you, Dr. Jacobe, and it's just been a
Having
pleasure having you here.
Bye bye.